Dan. So good morning, everyone. It's my pleasure to be here to introduce our speaker, Dr. Wendy Book. I really feel like I would not be where I am today without Wendy, who's one of my great mentors. So Dr. Book is a professor of medicine at Emory University School of Medicine and the Division of Cardiology in Atlanta, Georgia. And she's the director of the well-known and well-respected Emory Adult Congenital Heart Program. She's board certified in internal medicine, cardiovascular disease, advanced heart failure, and transplantation, and of course, adult congenital heart disease. She has over 2 decades of experience in adult congenital heart disease, including clinical and research experience. And in addition, her background is in heart failure and transplantation, which serves her well in her many roles at Emory. She completed medical school at the State University of New York in Syracuse, New York, and her internship and residency at Indiana University Medical Center in Indianapolis, Indiana. And then finally, her fellowship in cardiovascular disease at Emory University in Atlanta. And Dr. Book is really the kind of cardiologist who, in my opinion, she talks the talk and she walks the walk, so to speak. So if you're going in to see a sick patient, or you need help to make a difficult decision, or you need to finalize the manuscript, she's the kind of woman that you really want on your team. Still to this day, she's one of my go-to people. When I have a really difficult clinical question, I call Wendy, I say, Wendy, and I tell her about the case, and she listens thoughtfully, and then often at the end, she says, wow, that is a challenging one. I'm glad I don't have to deal with that one. But I'm glad you're here to help us deal with this. Dr. Book's works have been recognized in numerous publications, and she's received multiple awards, including the Emory University School of Medicine Alumni Award, the Nanette K. Wenger Distinguished Service Award for Outstanding Contributions to Emory University School of Medicine, and for the development of the Emory Adult Congenital Heart Center, which she was one of the pioneers. She's a member of numerous organizations, including the Adult Congenital Heart Association, the American College of Cardiology, the American Society of Transplantation, and the International Society for Heart-Lung Transplantation. And as I was saying, it's perfect timing for her to be here today because as we celebrate our 500th heart transplant and start to transplant more and more patients with congenital heart disease, I know her topic and her being here is very appropriate. So Wendy, thanks so much for joining us. We turn it over to you.
Well, thank you, Rob. It is a privilege and a pleasure to be here virtually today. I do look forward to seeing everybody in person. The topic of transplant and congenital heart disease could take an entire week. So we're going to kind of go through the highlights today and do the best we can to get through some of the material. And I'm happy to answer questions at the end. You all are very lucky to have Dr. Elder with you. He is brilliant, and I do miss working with him, although I do enjoy those phone calls about the challenging patient of the week. So I'm going to share here, and hopefully everybody can see the screen. All right.
Yep, you got it.
All right, I have no financial disclosures. I am an adult cardiologist and my focus will primarily be on adult congenital heart disease. There are some important differences between failing circulations in pediatric congenital heart disease and adults, but I'm going to focus mainly on the adult population. The objectives today are to recognize causes of heart failure and CHD circulations, recognize different types of Fontan failure, which is probably the most common problem to present to an adult heart failure program for advanced therapies in terms of CHDs. Understand the unique challenges presented by individuals with CHDs in need of transplant or mechanical circulatory support. And all right. This statement from 2016 from the American Heart Association is a great resource if you have questions about any particular heart defect. This is a good document to go to. And I will say that this was published before the new organ allocation system went into effect. So there are some important differences that I'll go through today. I'm going to briefly touch on biventricular circulations in the interest of time. This picture was shot right off the shore with the iPhone. So this is like an iPhone advertisement for their camera. The 2018 AHA guidelines address all of the different heart defects in terms of anatomy, physiology, and management based on anatomy and physiology. And they are a great resource for managing biventricular as well as single ventricle circulations. In a nutshell, those that have two ventricles and heart failure are managed in a way that is very similar to those who have acquired heart failure. So we think of them in terms of stage B, asymptomatic, C, symptomatic, D, end stage. And I'm going to focus mainly on end stage, those that need advanced heart failure therapies. But it is important to know that many of the therapies that work for acquired heart failure do work in biventricular circulations for those who are born with heart defects. There are some important differences, and it is good to know who is at risk for heart block or sinus node dysfunction before initiating a beta blocker, for instance. This is an example of tetralogy of Fallot. This is a common situation that may present with heart failure in two ventricle CHD circulations. Typically, those with heart failure have been out of care and come back with free pulmonary valve insufficiency, dilated right ventricle. They may have branch pulmonary stenosis, and they typically have right heart failure, plus or minus left heart failure. So this situation can be managed by replacing the pulmonary valve. Those who are too sick for open heart surgery are potentially candidates for percutaneous options in the cath lab. In this particular situation, this patient has a small right ventricular outflow tract and was able to have a stent placed in a native outflow tract with a Melody valve placed within that stent. So that's one of the ways to address pulmonary regurgitation in high-risk surgical candidates. Another way is these new Rvot stents that are in development. They look like an hourglass. They're designed for dilated right ventricular outflow tracts, which is the more common scenario in tetralogy of Fallot patients, and then a valve is placed within this stent system. Again, all helpful in terms of avoiding the operating room. These are still in clinical trials. The patients with heart defects who are at risk for heart failure that have two ventricle circulations also include Epstein anomaly, which is primarily a right-sided problem where the tricuspid valve is apically displaced. They often have severe tricuspid regurgitation. These patients are also at risk of left ventricular failure. Systemic right ventricles, again, a whole week in and of themselves, but that includes congenitally corrected transposition and DTGA. Those patients will develop failure of their subaortic right ventricle and may go on to require advanced heart failure therapies. AV canal defects may affect the left side. They're associated with mitral valve regurgitation, and they may go on to need transplant as well. And Schoen's complex is serial left-sided obstructive lesions. They can be extremely difficult to manage. They have very stiff, small left ventricles with small mitral aortic valve and coarctation. And those patients need really careful management. Now, I'm going to move on to single ventricle circulations, which is the most common scenario requiring advanced heart failure therapies, and I'm going to spend most of my time talking about that. My daughter, who by day is a math teacher, on the weekend is a scuba diver, and she took this picture of her favorite fish, the shark. She loves to jump in with them. So for those of you who are not familiar with Fontan operation, basically, if you were born with one ventricle, and at this point, the anatomy becomes less important for the purposes of this talk. Whatever that single ventricle anatomy was that required a Fontan operation, that single ventricle has to be used for the systemic circulation. When the baby's born, that single ventricle supports the systemic and pulmonary circulation that often leads to heart failure. They have profound cyanosis. So the Fontan operation uses that single ventricle to pump blood to the systemic circulation, and the systemic venous return comes back to the pulmonary arteries via a variety of different connections, but at the end of the day, the superior and inferior vena cava connect directly to the pulmonary artery, creating passive pulmonary blood flow. And this sets up a very unique physiology that is seen with the Fontan palliation that creates a number of different issues throughout childhood and adulthood. In the normal circulation, as you know, the right atrial pressure is typically lower than the left atrial pressure. You have a pump in the pulmonary circulation that allows the heart to overcome some degree of pulmonary vascular resistance, pumping the blood over to the pulmonary venous side, left atrium, left ventricle. In the Fontan circulation, you have no pump in the pulmonary circulation, and you have passive flow from the right atrium to the left atrium through the pulmonary circulation. As a result, your right atrial pressure has to be higher than your left atrial pressure from the day this operation is performed. And this operation is typically performed around preschool kindergarten age. So around age 4 or 5, the right atrial pressure goes up and stays there for the rest of the child or adult's life. The pulmonary vascular resistance needs to be low for this circulation to optimally work. If you have elevated pulmonary vascular resistance or problems with branch pulmonary stenosis, it can really impair the Fontan circulation. This is pediatric long-term outcome data, and the important thing to note here is at about 20 years after the Fontan operation, and remember this is done around age 4, about 74% are alive, 23% have died, 8% have been transplanted. If you are a parent with a sick 2-year-old, 20 years looks good. If you are a 20-year-old who's looking at this data, this no longer looks good. And these young adults who come to see the adult cardiologist, they want more. They want to do better, and they want longer-term survival. Failure of the Fontan circulation is common in the 20s and 30s and has been defined in variable ways in the literature. Some define it strictly as a heart failure definition, poor cardiac output, but with normal ventricular function. I like this definition better, which more broadly describes the whole spectrum of failure we see in Fontan circulations. And that would include death, needing to take down the circulation, conversion from an old style to new style Fontan, transplantation, protein losing enteropathy, plastic bronchitis, poor functional class. It's a long list that these patients may face as they age. Before we diagnose somebody with Fontan failure, we look carefully for anatomic reasons. Anatomic reasons are the low-hanging fruit and can often be addressed. In this MRI, these are the pulmonary arteries up here about 12 o'clock, and this is the Fontan connection, that IVC to PA anastomosis. And in this particular patient, there's stenosis there. So this patient will present with evidence of right-sided congestion, ascites, poor exercise tolerance, edema, and you can stent this anastomosis and relieve those symptoms. The other common scenario in adult patients as well as children is the development of tachyarrhythmias. These Fontan patients get intraatrial reentrant tachycardias. They can be fairly slow atrial rates, sometimes 120, 140, but they're poorly tolerated. They do not like fast heart rates. They need some filling time in order for the circulation to work. And these tachyarrhythmias can be very challenging to manage. We ablate them, they come back, we put them on antiarrhythmics, they break through. We put in atrial anti-tachycardia pacemakers as a palliative approach, but this is one of the potentially treatable scenarios, at least in the short term, for these patients. They also may develop clots in the circulation and lymphatic abnormalities that I'll get into in more detail in a bit. The point of this graph is to show that if you develop any of these three comorbid complications, that's the red line, your survival is much, much worse than those that don't develop these comorbid complications. And again, this is years post-Fontan. These are still children, and you can see how poor that survival is out 20 years post-Fontan if you have complications. I will point out that when I get to meet the Fontan patient, they're up here on the blue line. I'm typically meeting those that are doing well, that have survived. There's survival bias that accounts for some of the differences in what we see in adults and what my pediatric colleagues see in children. The adults typically have worse functional class. They have higher central venous pressure. They have lower systemic vascular resistance. Their cardiac index is similar to children. And liver imaging abnormalities, specifically liver imaging that looks like fibrosis and cirrhosis, is ubiquitous in adults. I find it helpful to think about Fontan failure in terms of physiologic and clinical phenotypes. It helps me sort through the patient in front of me, given all of the complexities that can occur in these circulations. My daughter took this picture as well. So this is basically a conceptual framework we published a while back to try to understand failing Fontan circulations. It's important to understand that patients may predominantly have one phenotype or another, but they certainly can have more than one within the same person. And the phenotypes can change over time. In children, systolic heart failure is a common problem in failing Fontan circulations. Unfortunately, many of those children die or require transplant. So we tend to see as adults more of those that have normal ventricular function. But the way I think about these patients is, do they have cardiac failure? And typically, if they do, their presentation is similar to acquired heart failure. They have both pulmonary and hepatic congestion. You can imagine if you develop left ventricular or right ventricular, if it's your single right ventricle, EDP of 20, Your right atrial pressure in a Fontan circulation is now 25. And this definitely impairs the circulation, leading to ascites, exercise intolerance, shortness of breath. They may develop cyanosis and edema. And this is characterized hemodynamically as low cardiac output and elevated vascular resistance on hemodynamic testing. So very similar to acquired heart failure. The Fontan failure with a normal heart may look on the surface similar to your acquired heart failure patient. They may have ascites and lower extremity edema, but on echo, their ventricular function looks normal. They have a normal ejection fraction. When you take them to the cath lab, their cardiac output is normal or even elevated, and their systemic vascular resistance is normal or on the low side. These patients typically are hypotensive, relatively speaking. And even though on the surface, they look like the heart failure phenotype, their physiology is completely different. And these patients typically look a little bit more like portal venous outflow obstruction. I'm going to explain in a little bit why that is. And they behave a little bit more like those that have portal hypertension from cirrhosis. And the reasons for it are different than in a cirrhotic patient, and I'll get into that in a bit. Lymphatic abnormalities are ubiquitous in the Fontan population. They have these dilated lymphatics. On imaging, just some of them are just massive, and they pop off into various areas. So they may end up leaking proteinaceous fluid into the intestines, which causes protein losing enteropathy. They may leak into the bronchioles, which causes plastic bronchitis, where they cough up these proteinaceous casts from their lungs. They probably leak into the peritoneum, giving you some, causing ascites. So some of the normal heart phenotype may actually have a degree of this lymphatic abnormality causing ascites. And their hemodynamics and ventricle are typically normal on testing. So I find it helpful to think through Fontan failure in this way so we understand what we're dealing with. Those that present with the heart failure phenotype are, again, very similar to those with systolic or diastolic ventricular dysfunction. Typically, they have a combination, and we typically manage them in a similar way to those that have acquired heart failure. Mortality after the Fontan procedure is most often due to heart failure or sudden death, respiratory failure, but they also, significant number die from renal failure, thromboembolic complications, PLE, liver disease, cancer, and infection. Fontan failure with preserved ventricular function and normal Fontan pressures is common, probably makes up about 2/3 of the Fontan failure we see in the adult population. And these patients, again, look like acquired heart failure, but they do not behave like acquired heart failure and actually get worse if you put them on treatment that you would use in acquired heart failure. These patients typically, again, normal EF, normal cardiac output, normal filling pressures. I've got interested in Fontan failure because early on in my career, I saw these patients who came to clinic and I just could not understand why they were doing so poorly. They had these big bellies, they had all this edema, they had exercise intolerance, they were developing cyanosis, and I took them to the cath lab and their EDP was 9 and their Fontan pressure was 12. And you look at them and say, but everything should be working and it's not working. Why isn't it working? So that's what got me interested in figuring this out. Fontan-associated liver disease likely plays a role in these adult Fontan failure patients with this preserved function phenotype. Fibrosis is very, very common in the adult population. Almost all of them have it. Preserved synthetic function is characteristic. So you do blood work and it looks normal, but that doesn't mean the liver is normal. And they have associated hemodynamic changes. I'm going to briefly kind of go through the circulation from the viewpoint of the liver and the gut, and bear with me on that. Here are some biopsies on the right of the liver. In typical acquired heart failure with congestive hepatopathy, you get sinusoidal fibrosis, which you can see up here. As things progress, you get fibrosis around the central vein, and you end up with portal fibrosis. So these are from a Fontan patient, so they have much more extensive fibrotic changes in the liver. Typically, stage 3 is what you see on biopsy. Then you see in acquired heart failure with congestive hepatopathy. This also tends to be very patchy. So in the middle of the liver, they may have less fibrosis. Out at the edges where the liver's been squished up against the capsule for 20 years, you may have much more advanced fibrosis. So liver biopsy doesn't tell the whole tale, but you can bet your Fontan patient looks something like this under the microscope. So how does this affect hemodynamics? Well, again, in the Fontan, we have removed the pump from the pulmonary circulation by necessity. And that means your hepatic vein pressures are high from childhood, early on, 20 years, high pressures. When your hepatic vein pressures are high and non-pulsatile, so they're both high and non-pulsatile, they're constantly statically elevated. It essentially creates back pressure on the portal veins. So you have this functional portal venous outflow obstruction. So even in the absence of frank cirrhosis, you have elevated portal pressures by definition for a long time. The portal veins are what predominantly perfuses the liver. And when the portal venous flow is reduced because of pressure upstream, you have upregulation of hepatic artery blood flow in order to perfuse the liver. And that's done through splanchnic arterial vasodilatation. And that leads to systemic vasodilatation. All of the upregulation that occurs in nitric oxide and other pathways will dilate your systemic vasculature as well. This can lead to reduced renal perfusion, and to maintain renal perfusion, you have to increase your circulating blood volume. So in a cirrhotic with portal hypertension, this is what goes on, and they typically have cardiac outputs in the 12 liters per minute range. Fontan patients, excuse me, cannot augment their cardiac output and sustain it at that level. So when that circulation begins to decompensate, you have redistribution of that extra blood volume in the form of ascites and edema. And this is one of the mechanisms leading to poor functional status, late after the Fontan operation. The difference between a Fontan patient and an acquired heart failure patient with RV failure, as you all know, when you develop right ventricular failure and an acquired heart failure, biventricular circulation, your prognosis is very poor. Patients with the Fontan operation are living with these elevated pressures for 20 or 30 years, and we just don't see that in acquired heart failure. In a biopsy study of Fontan patients, these are all adults, fibrosis was universal. Every single patient biopsied had fibrosis, and many had evidence of a decompensated portal circulation in the form of splenomegaly, ascites, and varices. Dr. Rob Elder, when he was at Emory, and Dr. Makoto Mori, who both of them are with you guys now, did a lot of work on Fontan failure. This is Dr. Elder's study looking at presence of varices, ascites, and splenomegaly. Time point 0 here is adult survival. So this is conditional survival to adulthood. And remember, I showed you that graph that a quarter of patients die in childhood. So these are the adult survivors that we're looking at this time point. Those that had only 0 or 1 of those 3 findings of a decompensated circulation had better survival than those that had 2 or 3. And this attrition rate is somewhere around 4% per year, which becomes important when you're thinking about transplant. This study from Boston looked at MELD-XI. The reason they use MELD-XI is MELD-XI takes the INR out of the MELD calculation. Many Fontan patients have an indication for warfarin anticoagulation, and therefore this was used. If you look at the equation, this is driven almost entirely by creatinine levels with a little bit of bili. Those that have a high MELD-XI score have very, very poor survival over the next 6 months. And again, this makes sense. Renal failure is a sign of a failing circulation. So these are some of the signs of circulatory failure that we see in Fontan patients. So how do we treat these patients? We use hemodynamic guidance and tailor therapy to their phenotype. Those with a low SVR may respond to vasoconstrictors such as midodrine. Typically, when I see one of these Fontan failure patients who has normal EF and normal hemodynamics, or what we call normal for a Fontan circulation, one of the first things I do is stop the vasodilator, ACE inhibitor. These patients do not tolerate ACE inhibitors very well when they have this particular phenotype. We'll use it in the heart failure phenotype. But with the normal EF, they typically do pretty poorly with vasodilators. Midodrine, if they have low SVR and evidence of poor renal perfusion with low blood pressure, can help improve their renal blood flow. And we have successfully managed a number of these patients through this strategy. Diuretics are very important to relieve congestion. The lower your pressures on the hepatic veins, the better the circulation, to a point. Cirrhosis, again, common. Hepatocellular carcinoma can occur in Fontan patients who do not have cirrhosis. So even those with advanced fibrosis can develop hepatocellular carcinoma. We monitor our patients with imaging every 6 months, and the rate of development of HCC is about 2% per year. Briefly, the pulmonary vasculature in the Fontan circulation is not normal. They have non-pulsatile flow. Once the Fontan operation is done and before the Fontan operation is done, many of them have excessive pulmonary blood flow in infancy. So these patients are at risk for vascular remodeling early and late after the Fontan operation. And you can imagine if you have passive pulmonary blood flow, that remodeling of your pulmonary arteries is not good for the circulation and your ability to augment cardiac output. This just very briefly, Fontan, pulmonary arterioles up top and controls on the bottom. And you have this intimal medial thickening in the Fontan population, very similar to what you see with pulmonary hypertension. The role of pulmonary vasodilators, when you start them, in whom you start them, how long, which one, is all under investigation currently. The abnormal lymphatic phenotype is challenging in the adult population. This is almost entirely protein-losing enteropathy. These patients have very low albumin levels, low blood pressure. They can be incredibly difficult to manage. Yoav Dori at CHOP is using embolization, lymphatic embolization, to manage some of these patients. And there are other centers around the country that are beginning to look at that. So Fontan failure, in a nutshell, is about more than the heart. It is a dysfunctional circulation that includes the heart. The treatment needs to be based on physiology, and that physiology changes over time. So what is true at age 4 may not be true at age 20 and may not be true at age 30. I'm going to talk a little bit about transplant and mechanical circulatory support in the CHD population, which is the ultimate treatment for many of these single ventricle patients. This is data from the ISHLT in the most recent era available. Those with CHD are the yellow wedges, and you can see they make up a minority of all transplants and a bigger proportion of those that are young adults. In a nutshell, transplant for congenital heart disease is high risk, high reward. So you provide very effective circulatory support and the best long-term outcome for many of these patients, but you do so with increased upfront risks. This graph looks at conditional survival. So to be on this graph, you need to survive to year 1. The yellow line is the CHD patients, and those that survive to the first year have better survival than those transplanted for other indications, but they have higher operative and surgical mortality. And the reasons for this are many. These are long operations. They have long ischemic times. To get into the chest after multiple sternotomies takes time. And once the surgeon gets into the chest, they often have to do reconstructions in order to put in the transplanted heart. So they may have to reconstruct pulmonary arteries, vena cava, figure out how to get the atria connected. Whatever that underlying anatomy is, if it's complicated, it will complicate the operation. As a result, bleeding is common, transfusion is common, and they develop early hemodynamic instability. As a result of all this, congenital heart patients have longer vent runs, longer ICU stays, longer length of stays, and more renal failure. This is an example of one of the causes of the excessive bleeding that can be encountered. And this is particularly common to the single ventricle population. They may develop aortopulmonary collaterals to help perfuse the lungs. Those come off the aorta. They may develop venovenous collaterals to pop off those high Fontan pressures back to the pulmonary veins. When the surgeon opens the chest, there's lots and lots of these, and they bleed and they bleed, and they can be hard to find and control. Many transplant centers, once somebody is listed for transplant, will take them to the cath lab and coil as many of these collaterals as they possibly can. And it's important to understand these collaterals are here for a physiologic reason. So if they're there to perfuse the lung, you're going to reduce pulmonary perfusion if you get rid of the aortopulmonary collaterals, if they're there to decompress the high Fontan pressures. When you coil them, the Fontan pressures go up and the patient may develop lower cardiac output. So this can be done, but we typically wait until we're ready to transplant before we do this kind of coiling. And the primary reason to do it is to reduce bleeding at the time of transplant. The question comes up not infrequently at pediatric meetings: why don't we just transplant everybody early? As many of you know, that's just not realistic. We have a limited number of donors. Transplant trades one problem for another. Patients have to take immunosuppression lifelong. Sensitization, so the development of HLA antibodies is common in people who have had previous open heart surgery and transfusions, so that may increase their risk for rejection and increase their time on the waiting list. Waiting list mortality for CHD patients is higher, and I'm going to share a little bit about changes in organ allocation to address this, and surgical risk is higher. So these are some of the causes of death after successful transplant. Graft failure being the most common, and there are a number of reasons for that, but these patients are also at risk for malignancy, infection, renal failure, and other problems. The failing Fontan circulation has a higher surgical mortality than those with acquired heart disease, about 20% averaged across centers. A more recent study has shown that the single ventricle transplant mortality at the time of transplant is similar now to other forms of heart defects, but is higher than acquired heart disease, non-congenital heart disease. One of the problems we run into is in the transplant world with acquired heart failure, we have a pretty good sense of when somebody is at that point where they will do better at the end of 1 year with a transplant than without a transplant. And we rely heavily on cardiopulmonary exercise testing and hemodynamics for that.